Okay, so welcome to the 25th edition of the webinars, the RedETSA webinar program. As I mentioned previously, we are going to have this webinar in English. Okay, later during the session for questions and answers, we can help with the translation if you can send us the question to through the chat. Okay, if you can please use the chat, or it's better. Or if you want to make your question, you can please ask for the microphone so we can open the microphone. Okay. This is the 25th edition of the webinars. Our webinar today is on health technology assessment and creating sustainable technologies, health technology management. As you know, we always record the webinars, so you can have access later. We're going to send the link if you want to disseminate with other colleagues or to watch again the webinar. Okay. Today we're very happy. I'm very happy to have with us for making this response for this webinar, making the presentation, Professor Tobey Clark. Professor Tobey Clark is the engineering supervisor of the Technical Services Partnership at the University of Vermont. For 22 years, Tobey was director with responsibilities for a multi-hospital healthcare technology management program and the university's prototyping and instrumentation development lab. Tobey has faculty appointments in the College of Nursing and Health Sciences and the School of Engineering. Tobey is the director of the WHO PAHO Collaborating Center for Health Technology Management at the University of Vermont, and also advisor to PAHO and WHO, and also led the development of a bilingual medical equipment technology online course at the PAHO Virtual Campus for Public Health, and also has served as a faculty for 17 PAHO and WHO sponsor healthcare technology management workshops. In fact, just a few days ago, a couple of weeks ago, we had the last version of the workshop was our colleagues from Caribbean countries who came to Washington, D.C. for a 3-day workshop with Tobey Clark and other colleagues from the Collaborating Center at the University of Vermont. So Tobey has been a very important collaborator for PAHO for many years. And we are very happy, and thank you very much, Tobey, for accepting the invitation to present this webinar today. So the floor is yours. Thank you very much.
Thank you very much, Alexandre. It's really a pleasure to be here. This presentation will be in English, and I hope that it will be what you're looking for. The basic focus of the presentation is basically after healthcare technology assessment to have a sustainable system through healthcare technology management. So the first point is why are we managing technology? So I have some figures here. I'm not going to have time to go through all the detail of it, but patient safety is really critical related to medical technology. Post-market surveillance. In the U.S., we recently reviewed our Food and Drug Administration adverse event reports, and there was over 600,000 reports related to medical devices in 2018. So it's that patient safety area is a huge problem. Hospital errors. We get several papers that have reported between 98,000 and 440,000 deaths per year related to adverse events from all causes. This is not just medical devices. but a percentage of that, maybe 13 according to Frost and Sullivan, is related to medical devices. It's also very costly. The patient safety issues, people have to stay in the healthcare system longer. They may have chronic problems. Another area is recalls. In the U.S., we have the FDA has a recall system, and we're finding that there's those recalls are going up, and most of them are related to software problems with technology. The next area, of course, is cybersecurity risks. According to our ECRI Institute, which is a international healthcare research organization, the number one risk in health technology is cybersecurity. FDA is very concerned. A lot of breaches have taken place. Things such as WannaCry was a ransomware which shut down the British health system. Cost. Well, the projections are for 2020 for $400 billion in expenditures related to medical technology, and the growth continues. However, a study that was done about 10 years ago showed that health technology is one of the prime drivers for healthcare inflation. More than half of the increase over a period of 1975 to 2008, according to our budget office, was related to the technology in healthcare. Related to cost is the important point that the acquisition cost, the purchase price, shipping, installation, is really a small portion of the total cost, and this depends upon the technology. Certain technologies, you would have more of this iceberg below the water, and other technologies it would be less. But certainly things like maintenance and staff training, consumables, upgrades, software licenses, it all adds up. So the consideration is the total cost of ownership related to the technology. There's also rapid change in the technology. 50% of all diagnostic treatment methods used today didn't even exist 10 years ago. As part of healthcare technology assessment, you're all involved in looking at the effectiveness. What are the outcomes? And now we have such things as robotic surgery that is becoming more common in healthcare. Is this, what is the total effect on outcomes of that? Complexity. In the U.S., our FDA regulates over 190,000 different devices manufactured by more than 18,000 different companies. A lot of product decisions. And two other important points that are paradigm changes is the convergence of technologies, medical devices, networks, telecommunication, and also devices that are partially a device and partially a drug, like the drug-eluting stent that's used for cardiac surgery. So what is technology management? Basic definition: management and planning support throughout the health technology life cycle. So it involves these points: replacement of technology, supporting the acquisition and deployment or installation of technology, and the specific management areas of maintenance, safety, compliance, education, and finally disposal. So here we have a life cycle diagram that our program came up with, and over here in the left side you can see that there's a request and assessment. So after the healthcare technology assessment, I'm going to talk about the activities that are related to the right side of this arrow. First of all, replacement of technology, which is driven in part by the experience that you have with your technology during its use. So for an assessment, I'm sure you want to have a product, not like product A, but more like product B that has a longer life cycle. This is a timeline for a technology from innovation, early diffusion, incorporation, then wide utilization, and finally obsolescence, which you want to occur later in life. However, all technology, particularly medical devices, have a finite life. So a technology replacement plan needs to be developed also in conjunction with a technology assessment. So when you're assessing new technologies, when you're going to put that technology into a budget for the health system, you also have to consider about replacing the existing technologies to keep the healthcare system running. And it's best that this is something that occurs in a planned fashion. This is just kind of an engineering diagram that just shows failure over time, something called the bathtub curve, which shows that we have a lot of devices that come into the system and they have what's called infant mortality, where they fail early on because of maybe manufacturing defects, improper testing, etc. But we're more concerned with the wear out failures that are on the other side of this bathtub curve, that eventually things wear out, they become obsolete. So these are questions about when you replace technology, and these are things that you don't want to have occur: when it fails at a critical time, when a physician returns from a conference and states the current technology is obsolete, when the department manager complains my equipment never works right, when undergoing repair it's found that parts and support are no longer available. And the new one is when you try to interface a device with the network and find out that it needs to be replaced. So these are all kind of emergent replacement questions that we really don't want to occur. We want to plan for the replacement of technology. So it should be health system or facility-wide, all the technologies. The objective criteria associated with that, a prioritized replacement plan, and a simple one. The simplest replacement might just look at the manufacture date plus life expectancy equals the retirement date. For many reasons, this isn't really adequate, though. Some of the life expectancy tables that are available, like from the American Hospital Association, are primarily for financial computation. We also have our Veterans Administration hospital system. It's 140 hospitals in the U.S. that comes up with life expectancy. But there's many more factors involved. It's better to have a quantitative measurement where you actually have collecting data throughout the life of the technology to determine obsolescence, cost effectiveness, safety, reliability, support, etc. It's absolutely essential for any moderately sized system to have a tool for healthcare technology management, and that's the computerized medical equipment management system. So that's basically a software package that maintains a database of all the information about an individual medical device, everything that has ever been done on that device, recalls, maintenance, parts, labor, etc. These are some elements that are included in a common computerized medical equipment management system. Of course, the equipment information, your inventory, the work that is preventive in nature, scheduled work, and unscheduled, which would be the repairs. The work order system, contracts, vendor information, purchasing, asset tracking, reporting. So there's the data, but what advantage does the computerized medical equipment management system have is you can develop a asset lifecycle profile. You can determine what are common failures for parts. You can look at investment, return on contracts, cost of maintenance, labor, utilization of assets, and mean time between failure. This is just a simple screen that is associated with the inventory, and it just documents the type of information, what type of equipment it is, manufacturer, model, department, location, purchase date, cost, etc. This is a common screen. And then you also will collect that data and come up with a history. And this is just an example history that would show replacement matrix here, the purchase price of the technology, the maintenance cost, and you can see as the life in years goes up, that cost goes up, and the basically the maintenance cost over the life cycle. So that gives you an idea of the ownership based on the medical equipment database. For equipment replacement, again, we talked about the age factor. Reliability is something you want to look at, number of failures, and the cost. So let's look in some detail related to equipment replacement. What are factors for replacement? Well, we have no service support from the company, from third-party groups, from your clinical engineering department or healthcare technology management department. If parts aren't available and there's no alternative support, no documentation, it's very difficult, if not impossible, to support the technology. So that's a primary factor in replacement. Maintenance costs, as those accumulate, we have to consider replacement more so. Reliability, that's another one. In terms of safety factors, we're talking about equipment-related incidents that occur, adverse events that occur in your health system, recalls that are occurring, especially the serious ones are unresolved, user problems, continuous problems with operation of equipment, maybe due to poor human factors, engineering, design. If regulations prohibit the use of the device, that's certainly a reason to replace it. And essential safety features. So another factor is, what is the risk associated with a device? If you have a high-risk device that its life support, if it fails, it could be a serious problem. You would go through a matrix perhaps like this to look at what the risk was of that device and prioritize that for replacement ahead of, say, a low-risk device. That's another factor of your equation. Standardization, alignment with the strategic plan. Standards of care are things like the cardiology technology, the physicians group that recommends certain types of protocols. They may also have equipment related to those protocols. Utilization, and very importantly, the cost advantages of new technology. If you have a technology that exists and you find that you can save money by getting a new one, that certainly is important. Today, this is another area that we have to be concerned of. If the device is going to be connected to the network. Kaiser Permanente, 30% of the devices in their system are connected to the network. If you have what's called legacy devices, they may have to be replaced. Sometimes they're very expensive to upgrade for connection. So this process, basically you're evaluating the database that you have from your computerized medical equipment management system, putting in the replacement cost, looking at all the inventory items, and coming up with a list of draft list, I guess you would call it, of replacement, which would then be vetted by other individuals, administration, of course, and other individuals outside of the clinical engineering department. Should be prioritized, so things that have to be replaced right away. Hopefully there isn't too much there, but planning for the upcoming fiscal year, the budget year, and even advisory information would be desirable if there's a major product line change, for instance. So a report would be generated. There may be options to direct replacement, use in a less critical application. For example, a defibrillator that's used in an emergency department could perhaps, even though it's fairly new, you're concerned that because of the high risk, but it still may be serviceable. That may be utilized in, say, obstetrics. So we tried to provide, in the hospital setting, a report to department managers prior to their budget submission and review that with them, looking at the replacement status. So it's an objective quantitative starting point for replacing technology. They're using this data that is available to the healthcare technology management departments, such as Senatech. Roberto Ayala, I noticed, was on this call, and he is in charge of that for Mexico. And non-technical factors can be incorporated, but you certainly want that data in the system to be able to make replacement decisions. So the next part of the life cycle for healthcare technology management includes acquisition and deployment. So this would be, acquisition is basically choosing between a vendor, one vendor and another. It isn't assessment where you're assessing a new technology to see if it's effective or not. At least that's the definition that I'm proposing here. So the purchase has been authorized, now choose between vendors. So see, these are some of the factors. You want to do an evidence-based review. It should be fair. You have to have certain factors that may be weighted higher than others. Service and support has to be included in that. Suggested that a decision matrix is developed to support that decision quantitatively, and some consensus. But before you purchase the technology is the time of maximum leverage. That is the take-home point. So a request for proposal would be developed, a tender that you would send out to companies that would state the specific requirements, the clinical requirements, the technical requirements. It's best to give the company some leeway in terms of the technology, so that if they have innovations, that they won't be eliminated from the proposal if it's something that's desirable. The support requirements should be clear. Reference list, environmental requirements for your installation, and other general terms and conditions, delivery, warranty, etc. This may be hard to read, but it just shows this would be a paper evaluation that might be done related to, in this case, C-arm, digital radiography, CT scanners, and radiological and fluoroscopic systems, RNF systems. So this just shows, the specifics, the specifications for certain major parameters, with the red highlights being differences between one vendor and another. Some of those may be advantages, some of those may be disadvantages, but they're at least understood. So this is something that your healthcare technology management department should be able to kind of put together if they have resources such as ECRI Institute, or just going through the spec sheets for the devices. I'm just going to talk about some key points that sometimes are not included in the acquisition process. It's very important for the device to be able to be usable. The ease of use is very important, reduces the number of adverse events related to use error. So human factors engineering involves very good design. If you're taking into consideration who's operating the equipment, is it a nurse, is it a doctor, is it a person that's like a clinical assistant and doesn't have a strong background maybe in the technical area, or is it a technologist? So good human factors engineering makes the device easy to use by those who are using the device, reduces the number of errors, and considers the kind of a science that is incorporated into the device. So this might be perhaps a clinical trial that you would use to select a device, and you would have some key factors that are related to human factors engineering. Another thing that is important is to review any adverse events that have occurred with the device. Freely available is from the FDA something called the MAUDE database, which has all the reports that have been sent to the FDA about medical device problems, not just those that resulted in death or serious injury, but also those areas where there was a near miss, where somebody could have got hurt. That's the voluntary reporting that exists. to see what kind of problems have occurred. And this is, again, is available to anyone. Purchase agreement, I just want to emphasize that it's very important to include the support attributes in the purchase agreement. If you only would purchase a service contract, you may not, in the future, if you decide to change from a service contract to your healthcare technology management group servicing the technology, if you don't have the documentation, you don't have the software updates, etc., you will not be able to support that. So that's critical. So again, in big red letters, time maximum leverage is before you buy. Negotiation, everything's negotiable. It's best if it's kind of a win-win type of process with the vendor. You should probably have a competitive process where it's not just one single vendor, but you have multiple vendors that are competing against each other. And go through the process, have your data in place. Purchasing decision, again, this is just a repeat of the previous slide that kind of goes through that process. But again, the take-home message, pre-purchase is a time of maximum leverage to get what you need to be able to support the technology, to be able to get the best total cost of ownership. Deployment is the next stage where you've decided what you're going to purchase. You sent your purchase agreement and your purchase order to the company, and now you have to determine the delivery, where you're going to put the technology to store it, the installation process, the training process, how do you accept it, commissioning, and final payment, hopefully, that you would the company would receive after you're totally satisfied that the technology suits your needs and is working correctly. So many times a new technology requires some planning of new facilities, and these are just some elements. The success of deployment really depends upon this planning. And these are some steps: the schematic design, the design development, construction documents, construction, and then occupancy in, say, a new unit that would support that technology. So project management, we don't have time to go through what project management entails, but that's another area that is really critical to the success of any technology, is the implementation and project management. Okay, now as we move beyond deployment, which is again related to that installation, training, and successful startup of the technology, now we're in the management part of the cycle. So this involves education, compliance, maintenance, safety. Those are key areas. And data collection is our computerized medical equipment management system, which feeds that data back into the planning cycle in terms of the new technologies coming. So healthcare technology, technical services, which would be healthcare technology management services, sometimes called biomedical engineering department, sometimes called clinical engineering department. A lot of names here, sorry. But there's the technical support of medical technology goes throughout the life of the equipment. And again, we're talking about the primary goal of the department is to have the equipment safe, effective equipment available for patient care. So safety is an issue, the quality of the equipment. Many times the IT connectivity is important, cost effectiveness, regulatory compliance. So what's the value of biomedical engineering department, which again, I guess you would call healthcare technology management department in some areas. Our Veterans Administration Hospital in the US, their biomedical engineering department is called healthcare technology management. So what's the payback? Well, you have improved patient care through accurate diagnosis, effective therapy, reduced costs. You save with management and direct service if that department is able to support that technology. A safer environment, finding safety issues before harm is done. Making sure that the devices are accurate and ready for use, and the patients are then more satisfied and the staff has better morale. It's a good investment. So what are some of the tasks that the biomedical engineering department? One area is maintenance, of course. So you have the maintenance tasks related to those services, monitoring the costs, setting benchmarks. What is your comparison over time, and also what is your comparison versus other departments that are doing the same thing? And how available is the equipment, which sometimes is expressed as downtime. Your computerized management system should be in place and suited to the need of the department and the health system. Staff, tools, parts, documentation is all necessary. Also, the management of contracts, service contracts. When you sign a service contract, it doesn't mean that you don't have to worry about service anymore. You just call the company. Well, you need to monitor the company. You need to interact with them. There's different processes that are in place. Many times the service contracts, even if it's sold as a full service contract, doesn't cover certain parts, doesn't cover holidays, weekends, etc. Or there's an extra cost associated with that. So that all has to be managed. So in planning for a department, again, the plan includes the resources that you need, things like equipment. Obviously your staffing is very important, your biomedical engineers. Understanding what the clinical need is for the biomedical engineering department. Our department not only provides service on equipment, but we also participate in the open heart surgery program at our university, where our technical staff is in there for every open heart case. Any of those procedures, they work with the intra-aortic balloon pumps and cardiac assist devices. So if that's a need, the biomedical engineering department is available to do that. Vendor issues, logistics, cost, and again, planning involves trying to get this accomplished before you purchase the technology. This is just a list again of the activities related to maintenance. Corrective maintenance, repair, planned maintenance, or preventive maintenance and inspection. Those are the two primary areas. Upgrades are becoming more important. Everything's software driven. Doing upgrades is not simple because once you change the software in one component of a system, you have to ensure that that software will be compatible with other components in the system. Installations, overhauls, refurbishing, and maintenance by users. There's some maintenance that also is required by the people that are just using the equipment, not the biomedical engineering staff. So what's the breakdown for medical equipment maintenance expenses? Imaging is a large percentage of maintenance expense, things such as MRI and CT scanners. Of course, the laboratory, surgery, etc. is another area where high maintenance expenses can occur. There's different ways of paying for the maintenance, and these are, I'm just going to go through some of these, and they fall into two categories. What is the provider of your maintenance? And generally it falls into the manufacturer via service contract, and there could be many options for that service contract. The health system, which would be the Department of Biomedical or Clinical Engineering. This would be also called your Healthcare Technology Management Department. An outside independent service organization, unaligned with the manufacturer. And the last is maintenance insurance. Maintenance insurance is interesting. It's basically insurance on the repair of your technology, which is generally less expensive than a service contract, but allows the manufacturer to service the technology. So in terms of plans, you can do this under a contract for several of these areas. You can pay also by the hour in parts. And of course, you can lease equipment, and there's other options that are available for paying for maintenance. So in terms of a service contract, manufacturer service contract, that might be utilized typically on your high-end equipment. There are certainly advantages to that. It's very simple to set up. You can build it into the purchase sometimes, along with other things. And the perception is that you have preferred status and there's less paperwork and management. The disadvantage is that it's the most expensive approach to maintenance. There's a lot of hidden costs. There are long contracts that have to be reviewed, and there's limited flexibility. Sometimes they automatically renew, so you have to be concerned that you would, if you were going to change, that changes with your wishes. Self-managed program, which would be the clinical engineering department itself servicing the technology. You would have probably the lower labor costs associated with that, faster response as your staff is right in the hospital, and it would be vendor neutral in terms of the technical aspects because it's not a conflict of interest. However, there are some disadvantages that many of the staff working in the healthcare technology managed department are not specialists. They're generalists. The training may not be available to them. The documentation or parts may not be available to them. And there's a lot of duties that they may be doing. The next area is independent service organization, which again is an independent organization, not associated with the manufacturer, not associated with the healthcare system, that are independent. They're typically people that work for a company at one time and then they went out on their own and started a company. So those rates are typically lower. They may be local and they may be cover multiple brands of devices. The disadvantage, you have to look very closely at the stability and reliability of the independent service organizations. They may not be able to get parts that are needed, and they may be concerned about training. The last area, again, is maintenance insurance. And, again, this is something that can be a cost reducer. On average, the program that we have at for our hospitals, it's somewhere between probably around 23% cost saving over service contracts, and it does allow the manufacturer to do that service. You can put a lot of contracts together, and there's good documentation. But it does, maintenance insurance does require careful management. For some programs, there's a reimbursement cycle that leads to delays, sometimes rejection in claims, etc. Lastly, time and materials service. So this is basically you pay as you go. You pay by the hour, you pay by the part. You call people in when things break. You call people in when they should do preventive maintenance. You get good documentation because every time they come in, you get a document from them. A lot of flexibility. The problem is that when there's a major failure, this may cause problems with your budget. So for instance, if you have a CT scanner and the tube goes on it unexpectedly, that could be a big expense that may even be higher than the service contract cost. Typically, healthcare systems have a mix of these various areas, the in-house or the clinical engineering department, the time and materials from the outside vendor, service contracts, and managed maintenance insurance. So in summary, healthcare technology management is something that kind of follows the assessment decisions. So after a technology is determined to be something that improves the outcomes, has the benefits, the costs, etc., have been reviewed through the assessment process. The healthcare technology management follows that. Many times the healthcare technology management is involved in evaluating equipment for replacement. That's another factor that goes into the budget of the technologies. Acquisition or procurement is many times called procurement. Addresses the needs, so the specific needs associated with the already identified purchase of a technology. Now you're choosing between vendors. And this is a time of maximum leverage with those vendors for the healthcare system. Deployment or implementation involving installation of the technology, training, all the commissioning parts of the process. It's really critical for the success of the technology. I think you're probably aware that some perhaps great technologies that could have been very successful maybe ran into some problems during the deployment or implementation process. Maintenance options do exist if you plan for them. So you need, if you're planning on supporting the technology by your clinical engineering or health technology management department, you need to plan for those things to occur so that you have the documentation, you have the tools that you need to support the technology through your internal department. Safety, something that needs to be considered throughout the life cycle, along with education and compliance with regulations and alignment with standards. So a biomedical engineering department has a high value to the health system, and healthcare technology management is an important process that should take place following the assessment. So I have time for questions.
Thank you very much, Tobey. Excellent presentation, and thank you for keeping the perfect time. It's exactly, in fact, it's less than 45 minutes. So thank you very much. So I will now accept questions. Please, if you want to use the mic, please raise your hand or send me a yes. It's better if you send a message saying that you want to use the microphone, because I cannot see all the hands when you ask for the floor here in the screen. So I have already a question, and that's our colleague from Mexico, Roberto Ayala from Senatec. What could be? Thank you very much, Roberto, for your question. What could be the right definition for obsolescence, being one of the primary reasons many users use to want a medical device replaced? It cannot be just age, because there are old equipment still working safely and accordingly. Thank you, and congratulations for such a great presentation. Thank you very much, Roberto. Excellent question. So, Tobey, please.
Yeah, that's an excellent question, Roberto. Obsolescence is not a quantitative factor. It's something that is determined qualitatively by looking at the technological status of a particular technology. Obsolescence is really related to the other factors. Something would be obsolete as it no longer has the functional capabilities to deliver the standard of care that you're looking for in the healthcare organization. Or it could be obsolete because does not connect to the network, and you require that particular technology has a network connection to send data to the electronic health record or to other network components. So obsolescence is something I hate to use in general, because it is very qualitative. It's not something that has a specific factor that you can put towards it. It could be one of many factors related to the areas that I discussed.
Yeah, and Roberto is mentioning that he totally agrees with your answer. Thank you very much, Roberto. Thank you, Tobey, for this very clear answer. And Roberto is as many of you know, is one of the leaders and one of the directors in the Senatec. So it's facing very important challenges in Mexico at the Senatec, which also a WHO Power Collaboration Center on Health Technology Management. So have two representatives from collaborating centers in this meeting from Vermont and from Mexico, Senatec. Thank you very much for your participation. Please send us the questions in the or via chat or the question answers space here. I would like to make a comment, and one of the reasons I invited Tobey to make this presentation today, and it's because we are trying to promote in the region this concept of integrated approach. And what we mean as integrated approach when we talk about health technology assessment and decision making is because in some it's very often that people look at the cycle, the technology life cycle in a very fragmented way. So we can see some, in my experience as a regional advisor, so traveling and going and to the countries and working with them to support in technical cooperation, support into establishing new policies on assessment, management, and regulation. It's very often we can see a fragmented approach in terms of, so there's a group of people or working with assessment dimensions. Another one work more on management side on the use, and another group more on the decision making component. And so the idea is to try to integrate. I'm not saying merge the groups or merging institutions that are doing different roles, but try to look at this as an integrated approach. And I'm glad that Roberto Ayala is here, and also Veronica Gallegos from Senatec, which is, of course, member of RedETSA and WHO Collaborating Center, because Senatec, in my understanding, uses this integrated approach. If you look at the way Senatec is organized, and this, you can see the assessment component there. You can see the management component. So that's the reason I invited Tobey to talk about, as you see in the title, so HTA and making sustainable, creating sustainable technologies in integrated this in the health technology management. I see very often, as I mentioned, that so people, countries, institutions doing good assessments, but they do not manage to integrate this as making sure the technologies are being used in a rational way. We talk about the rational use of medicines a lot, but usually we don't talk about the rational use of devices, equipments. Usually we use health technology management. Health technology management is exactly making sure that we are making a good use and a wise use of those devices. So that's the reason I wanted Tobey, and it was, I think, very clear, and the need of integrating those concepts in the decision making process related to medical devices, in specifically medical technology, medical equipment. So let me go back to the questions here in the chat. And now we have a question from Mirta Moran. I'm very glad Mirta Moran is here with us. And Mirta Moran is the director of biomedical engineering at the Ministry of Health in Paraguay. And Mirta is saying here, excellent presentation. Congratulations to the team. About the cost of maintenance, is there a maximal percentage of the initial investment in biomedical equipment related with age? Thank you, Tobey.
It kind of, thank you for the question. It's very good. maximum percentage kind of depends on the technology. If you're talking about, say, something like an infusion device, a simple infusion device, typically the percentage of purchase costs that you would spend annually to support that might be 3%, something like that. If you're talking about a nuclear medicine system, some other high-end technology, the costs might be 13%. So I think it sort of depends on the technology. Some studies have put the cost associated with the life cycle as it approaches 50%. Others have said 100% of the purchase price that you need to consider replacement. So there really isn't a percentage. What you look for is increasing unreliability. You look for increasing costs related to maintenance over time. So if you have your first 5 years are good, then all of a sudden you start to have much higher maintenance costs, and it gets say double the average, which according to studies I've seen is somewhere around 5% of the purchase cost per year for maintenance. Then you have to consider that for replacement.
Okay, thank you very much. I have a comment here from Livia Lemos. Livia Lemos is from CCATAS, which is the HTA collaborating center for the Ministry of Health in Brazil at the Federal University of Minas Gerais, and also a RedETSA member. Livia is making a comment regarding what I just mentioned about the integrated approach. I said, excellent presentation to Tobey, thank you very much, and great discussions. We strongly agree with you, Alexandre, regarding the integrated approach. So thank you very much, Livia, for your comment. So I don't have any other question in the chat, so I'm asking our colleagues Veronica Gallegos and Nilda Enriquez, who are helping me, and I would like to thank a lot Nilda and Veronica for helping me a lot with the session. Also Francisco Cacavo, who is also always coordinating the program. Now he's kind of, well, he just started a new assignment, Minister of Health in Argentina, so he would not be able to be with us and coordinating the program anymore. So I'm very grateful that Veronica Gallegos from Senatec has volunteered to help us with the webinar program from now on. And so thank you very much, Veronica. And also Nilda Enriquez is my colleague. She's not in Washington right now. She's from Mexico, but they're both working and helping me a lot with this. So thank you very much for that. So they are going to let me know if there's any other question at the Q&A session that was a little bit below the chat that I cannot see right now. So please let me know in a few minutes. Let me see now. I think there is one. Yeah. So there's one question here from another WHO PAHO Collaborating Center. So we have a very nice meeting of collaborating centers today. From the Institute of Biomedical Engineering, IEB, at the Federal University of Santa Catarina in Brazil. So it's the question is from Flavio, Priscilla, and Renato. That's our very important collaborating center there in Brazil. So thank you very much, Flavio and Priscilla. There are, I will translate the questions in Portuguese, so give me just a few seconds. They are asking if there is any criteria for the planning, for the equipment planning, that those equipments that are not in that not being manufacturing anymore. So the question is, the first question is, if there is any criteria that we can use for planning for those equipments that are not being manufactured anymore, but they are still useful, they are still important, and with acceptable performance and the health service. So that's the first question, and there is another comment from them. There's a lot of time in the management process. There are equipment that can still be used for a long time, and the replacement is always very costly. No? In this sense, we would like to know how could we plan ahead for those cases. Congratulations for an excellent presentation. Tobey, back to you.
Okay, in regards to the first question, and again, I really appreciate the comment from IEB in Florianopolis, in Renato's group, of course, along with Roberto Ayala and Senatec. Really depends if the equipment is no longer manufactured. The manufacturer, many of the major manufacturers will provide an end of support date that would indicate when parts and service from the manufacturer are no longer available. And this is something that we have our students at the university researching, typically our summer time project, to find out the end of support date for the manufacturer. Now, this, of course, doesn't mean that you can't support the device if you have parts available from either a third-party group, independent parts provider or service provider, or you yourself have that capability. But you know, that is one thing that to consider in replacing devices, that that end of support date from the manufacturer, alternative support from other places. But you do have to plan for it. And I mentioned in the replacement planning process that we would send out an advisory when say if you have a major technology system like an intensive care unit system, when the manufacturer drops that particular product line and is introducing a new one, that would be an advisory that would be made to the individuals that are responsible for budgeting for the technology. The second question is more difficult to answer because there's so many factors related to the replacement process, and I think you have to look at all those factors.
Okay, thank you very much, Tobey. So we have a question from our colleagues from the Caja Costarricense Seguro Social, the Social Security agency in Costa Rica, and Alfonso Rosales, and I think there's the group that are other people, but I can see only the name of Alfonso Rosales. So my apologies if I cannot read all the names here. But so our colleagues from La Caja, they are saying, Mr. Tobey, thank you very much for your interesting presentation. Would you comment on how a replacement plan would be affected considering public versus private sectors? Which are the most important aspects to be considered in each case?
Well, that's an interesting question, and thank you very much for that. It's been a long time since I've been to the La Caja myself, but I think in terms of the public sector, you have different factors affecting the budget process for replacement, and my sense is that you would have to be more proactive and get that recommendations out earlier in a public sector environment, whereas private sector, I think, sometimes is more flexible, is able to be more agile in replacing technologies. So the process aspects are important considerations, and it differs depending upon your organization that you're associated with for making those replacement decisions. So I'm not sure if I'm answering your question, but I think it's basically largely process differences between the public and private sector. Alexandre?
Sorry, I think I was with mute, correct? You could not hear me?
Yes.
Sorry about that. So we have another question here from Andrea Garcia. Thank you very much, Andrea. They say thank you, Tobey, for a great presentation. So Andrea's question is about. It said, with the context provided by Alexandre regarding the integrated approach, how can we, it said, to brief the relationship between health technology management and health technology assessment?
Well, I think the relationship has to be close. There has to be communication, certainly. As part of the presentation, one of my goals was to just emphasize the fact that you can have an excellent healthcare technology assessment process and go through and do a great analysis of a technology, which maybe you feel is going to be very successful, but the implementation of that technology, which is driven in many ways by the healthcare technology management of that, has to be an important part of the success of any technology. It's not just the assessment; the management is really critical. So I think for Andrea, are you from the Health Ministry in Colombia? Is that maybe I've met you before? It's basically to show your value as a healthcare technology manager, as a clinical engineer, biomedical engineer, that it's an important part of the health technology process, and the success and the sustainability of the technology has a lot to do with the management.
Excellent. Thank you very much. So I received also a message from our colleague, a very important expert on health technology management as well, Diógenes Hernandez, from Dominican Republic. So greetings, Diógenes. Thank you very much for your participation. Diógenes is mentioned excellent presentation, and he's mentioning that Dominican Republic is right now organizing or reorganizing Department of Clinical Engineering around country, and he's saying that there's needs of support from the collaborating center, and of course we'll be glad to work with our collaborating center to help implementing HTA, HTM strategies, and why not HTA as well, strategies and policies in Dominican Republic. And so thank you very much, Diógenes, for your participation. I see other comments here from La Caja. So I asked our colleagues, Alfonso and other colleagues from La Caja, if they want to use the microphone or if there is anything that you want to complement in your previous question, or if not, if you're happy with the answer, please let us know, because there's a few comments here in the chat that I was not sure if you want to complement the questions or explain a little bit in more details. So please send me a message here in the chat if you want to use the microphone to explain. Okay. I think they are mentioned that it was okay. They're happy with the answer, so thank you very much. I don't see any other questions, so I assume that everybody is happy with the session, and we are approaching 12. Yeah, now it's 12:10, 12:11 already. So, but we still have a couple of minutes if you want to send us a few additional questions. But if not, I would go to a wrapping of the session. Before we close the session, I would like to thank again, of course, all the participants. We had, I think at some point and during the presentation, we have around 65, 68 participants, which is a great number. Thank you very much for your participation. Of course, thank you very much to Tobey, but I would give the opportunity to Tobey to make final comments. Also thank you Francisco Cavo, Nilda Enriquez, Veronica Gallegos, who was helping me a lot with the webinars. Thank you very much, all RedETSA members. All the participants who are not RedETSA members, but also always come to participate in our RedETSA webinars program. And we have a final question before we have final comments from Tobey. I would ask Tobey to answer this final question and then making your final remarks, and then I close the session. So we have 5 more minutes until we close. So here is the question is from Murilo. I'm not sure it's Murilo Conto, it's Murilo Freitas. I'm assuming it's Murilo Conto. So thank you very much, Murilo, it's Murilo Conto. Thank you very much, Murilo Conto, for your participation. And the question is the following. Recently, we have problems in Brazil with hackers invading the CT scan softwares and changing the exam's results, which is scary, of course. Do you know some initiative to avoid this problem with risk management and the whole issue of cybersecurity? So it's a very important question, Murilo. Thank you very much. I just came from the International Medical Device Regulators Forum in Moscow a few weeks ago, and one of the new working groups is on cybersecurity. So it's a very important, it's a very hot topic. And so, Tobey, please answer the question from Murilo Conto, and then your final remarks, please.
Yes, cybersecurity is kind of an exponentially increasing problem that we're seeing with all kinds of systems that are on the internet, networked, etc. But for medical devices, it can be deadly. So, in terms of the measures that we're trying to take in our system is to, first of all, at the assessment phase of any technology that may be coming into the health system, we require a report called the MDS2 form, which indicates various risks and vulnerabilities of a technology that's being considered for purchase. This is something the manufacturer's organization in the U.S. at least has set up. And this form helps understand what the risks might be related to a technology. And if there are risks, maybe it's the operating system of the technology is vulnerable. It may be the ports of the system that allow access may be vulnerable. That you go through a mitigation process. Sometimes it's done by the manufacturer, that you would get them to make some changes. That's difficult, of course. Or it may have to be done by the healthcare organization. So for the example, for the CT scanner, you would want to put your imaging technology on an isolated network that would not be vulnerable to outside hacking. That would be an important step. You would want to perhaps monitor the activity on that network if there's unusual activity. So for instance, there are products you can buy to monitor the network activity on medical devices. Maybe there's all of a sudden you're getting downloads from a country not to be named that is going into your CT scanner. That would be an unusual activity. So I think there's glad to talk more about that. One thing that we do have that maybe Alexandria had mentioned is on PREAS, on the PAHO website, we've set up a healthcare technology management community. And there's a presentation there that was done, I did on cybersecurity related to medical devices.
Thank you very much, Tobey. Yeah, we just created this community of practices, and we thought at the beginning was targeting to English-speaking Caribbean countries. Is in the community of practices was originated as part of as a kind of one of the results from the workshop for the Caribbean countries we've mentioned. But of course, if there's any other country that is not in Caribbean country but would like to have access, so they'll just drop me a message, and we'll be glad to incorporate you. And if you need you want the presentation, also we can share the presentation on cybersecurity with you. We are discussing this issue as well, as I mentioned, the regional working group for medical device regulation. When we may have a working group as well in the region. And then the last meeting that we have for the regional meeting medical device regulation in El Salvador, we also had a session that was hosted in the regulatory authority, the DNM, in El Salvador. We have a session on cybersecurity as well, and that meeting we had Tobey Clark with us again. So as usual, we're always collaborating. So Tobey, I think we're wrapping up the session. So if you can make just final comments, final remarks before you close.
Yes, I appreciate you attending this session, and hopefully some of the key points. The message is basically that for sustainability of technology, that the technology needs to be managed throughout its life cycle. I want to thank very much Alexandre, Veronica, Nilda, and especially Francisco, who I understand will not be on part of the general PAHO staff, who's assisted me over many years, and I appreciate your work. Thank you.
Thank you very much, Tobey. So as I mentioned, the webinar was recorded. So if you want to watch again, or the ones that you cannot share with your colleagues and in your institution. So we are going to the link will be available early next week. So please let me know if you don't receive it. And also, of course, in the redetsa.org website, you can also early next week we're going to post the presentation there. Okay. So again, I think I make all the thank you very much again to all the participants, again for our team, and of course especially to Professor Tobey Clark for an excellent presentation, and for all the participants for excellent questions and an excellent discussion. So thank you very much again for your participation. Have a wonderful weekend with your families. Thank you. Bye-bye.
Thank you.